So this is an apical 4 and apical 5 chamber view in a patient with acute shortness of breath and apparent decompensated heart failure. And we can see the right atrium, tricuspid valve, right ventricle, interventricular septum, left ventricle, mitral valve, left atrium, the interatrial septum, and at times we're getting a look at the LV outflow tract and aortic valve. And really just recording this to illustrate the appearance of aortic stenosis. And if we take a close look at this clip, and I'll go ahead and stop it here, we've got a thickened aortic valve. It's more hyperechoic than the adjacent valves. It doesn't tend to open in a way that can be easily observed over the cardiac cycle. The valve leaflets just aren't moving freely. And if we compare them to the motion of the tricuspid and the mitral valve here, you can see that the aortic valve just kind of hinges a little bit but doesn't really move and open freely the way the other valves do. And in a patient with heart failure or chest pain or syncope, just being able to observe that the valve looks abnormal and isn't visibly moving normally is plenty to go ahead and trigger a focused cardiac workup with a comprehensive echocardiography and involvement of the cardiology service. Assessment of the severity of AS can be difficult and involves determining flow velocities across the valve, and really something better reserved for comprehensive echocardiography. But as ED providers doing focused cardiac ultrasound, if we're able to recognize that somebody has an abnormal appearing aortic valve in the right clinical setting, this can lead to an expedited workup and help provide the patient with the care they need.